Okay, let's unpack this. Imagine your body as a perfectly balanced ecosystem, really delicate, intricate system where every single component plays this crucial role. What keeps everything in harmony, preventing chaos. It's all about managing your internal ocean, the fluids, electrolytes, and acid-base levels.
Right.
Today, we're taking a deep dive into this fundamental operating system, helping you grasp not just what keeps you ticking, but why it matters so profoundly.
And what's truly fascinating here, I think, is how interconnected these systems are.
Yeah.
A tiny shift in one area can create this, well, ripple effect across your entire body,
Right.
influencing everything from the rhythm of your heart to how your brain actually thinks. Our mission today is to guide you through these crucial mechanisms that maintain your delicate internal balance,
Okay.
so you understand the logic behind common health issues and how your body constantly works to protect itself.
We'll be digging into the distribution of all that water inside you, the unseen forces that move it around, the sometimes surprising causes and effects of common imbalances like swelling,
Edema, yeah.
and the ingenious ways your body regulates key players like sodium, potassium, and pH. Get ready for some serious aha moments that might just change how you think about your own body.
Definitely.
So let's dive right into your body's fluid blueprint. When we talk about total body water, or TBW, what exactly are we looking at?
We're referring to all the fluid coursing through you. For an average adult, that's roughly 60% of your body weight.
60%, that's a lot.
It really is. Think about it. If you weigh, say, 70 kilograms, which is about 154 pounds, around 42 liters of you is pure water.
Wow.
And this isn't a static number. It actually shifts throughout your life. Babies, for instance, they're like little water balloons, maybe 75–80% water at birth.
Higher than adults then.
Oh, yeah.
Yeah.
But as we age, that percentage drops. Older adults see a further decline, partly because of reduced muscle mass and maybe kidneys that aren't quite as sharp at managing fluids anymore.
So it really shows how dynamic our internal environment is.
Exactly. This constantly changing internal composition really highlights that.
Now, this water isn't just sloshing around in one big pool, right? The body divides it up.
That's right. Your body cleverly divides it into distinct compartments or spaces. The largest by far is the intracellular fluid, or ICF.
Intra meaning inside.
Precisely. It's all the fluid tucked inside your billions of cells. This makes up about 2/3 of your total body water, so the majority.
Okay, 2/3 inside the cells. What about the rest?
The remaining 1/3 is the extracellular fluid, or ECF, all the fluid outside the cells.
Extra meaning outside. Got it.
And the ECF has two main subdivisions we focus on most. There's the interstitial fluid.
Interstitial.
Yeah, that's the fluid filling the tiny spaces between your cells, kind of bathing them in nutrients. And then there's the intravascular fluid.
Intravascular,
Yeah.
within the vessels. Blood.
Exactly, the fluid within your blood vessels, essentially, your blood plasma. There are also some smaller, more specialized fluids like synovial fluid in joints or cerebrospinal fluid, but interstitial and intravascular are the big ones for ECF.
Okay, so fluid inside cells, fluid outside bathing the cells, and fluid in the blood. But what's actually in these fluids, that's where electrolytes come in.
Yes, electrolytes. And here's a really crucial distinction between the inside and the outside of your cells. It's quite dramatic, actually.
How so?
Well, outside the cells, in that ECF, you find really high concentrations of sodium ions and chloride ions.
Okay, sodium and chloride outside.
But if you look inside the cells, in the ICF, it's packed with potassium ions and phosphates, a completely different picture.
So high potassium inside, high sodium outside. How does that happen?
That's not accidental.
Right.
It's actively maintained by these tiny molecular machines in the cell membrane. We often call them sodium-potassium pumps.
Dump pumps, like they're physically moving them.
Exactly. They're constantly working, using energy to push sodium out of the cell and pull potassium in.
Like microscopic bouncers at the cell door, making sure everyone stays in their assigned section.
That's a great analogy. And this careful electrolyte distribution is fundamental. It's not just about electrical balance, though that's key. It's what allows your nerves to fire impulses and your muscles to contract.
And it affects water movement too, you said.
Critically, these concentration differences are the main drivers dictating precisely where water decides to go throughout your body.
Which brings us nicely to the dance of water movement, as you called it earlier. Between the blood plasma and the interstitial fluid, how does water move?
Right, between plasma and the interstitial space, water is constantly shifting. It's driven by this balance of pushing and pulling forces, collectively known as Starling forces.
They're Starling forces, okay.
Think of hydrostatic pressure as the push, It's essentially your blood pressure inside the capillaries, pushing water out into the surrounding tissues.
Okay, blood pressure pushing water out. What's the pull?
Counteracting that push is oncotic pressure, or colloid osmotic pressure. That's the pull. This pull is mainly created by large protein molecules, especially albumin, that are dissolved in your blood plasma. They can't easily leave the capillary, so they draw water back into the capillaries.
So it's like a tug of war. Push out, pull in.
Exactly. And typically at the arterial end of a capillary, the hydrostatic push is stronger, so fluid filters out. Then, towards the venous end, the oncotic pull becomes stronger, drawing most of that fluid back in.
Most of it. What happens to the little bit left over?
Good question. Any excess fluid left behind in the tissues, along with any small proteins that might have leaked out, isn't wasted. Your lymphatic system acts as a brilliant drainage network.
Ah, the lymph system.
It collects that extra interstitial fluid and those proteins, and eventually returns them back to your bloodstream, completing the cycle. It's a really important overflow mechanism.
Okay, that's movement between blood and tissues. What about between the tissues and the inside of the cells?
Between the ICF and the ECF, the main driver is osmosis.
Osmosis.
Right.
Water moving to balance out concentrations.
Precisely. Water will always move across cell membranes, usually through special channels called aquaporins, from an area where solutes are less concentrated to an area where they're more concentrated, trying to equalize things.
So it chases the dissolved stuff.
You got it. And that's why sodium's balance in the ECF and potassium's balance in the ICF are so critical. They are the primary solutes, the main magnets for water in their respective compartments.
But what happens when this perfectly choreographed dance gets out of sync? That's when we run into problems like edema.
Exactly. Edema is essentially just an excessive accumulation of fluid within those interstitial spaces, the fluid surrounding your cells. It's not really a disease itself, but more a sign that something's gone wrong with those Starling forces we just talked about, or maybe with the lymphatic drainage.
Okay, so what could cause that? What makes fluid build up there?
There are four main physiological mechanisms. One common cause is increased capillary hydrostatic pressure. The push force gets too strong.
Like higher blood pressure in the capillaries.
Yes. This can happen if there's a blockage downstream in your veins, like a blood clot, maybe thrombophlebitis, or even just tight clothing or standing for a very long time. Or it can happen if your body is holding on to too much salt and water, which increases your overall blood volume and pressure.
Ah, like in heart failure.
Congestive heart failure is a classic example. If the heart can't pump blood forward effectively, pressure backs up in the veins and capillaries, pushing fluid out into the tissues. Kidney failure, or liver cirrhosis, can also lead to salt and water retention, causing the same effect.
Okay, so too much push. What else?
Another major cause is decreased plasma oncotic pressure. That pull force gets too weak.
The protein pull.
Exactly. This usually happens if you have too few plasma proteins, especially albumin, circulating in your blood.
Why would that happen?
Well, maybe the liver isn't producing enough albumin, like in severe liver disease.
Yeah.
Or perhaps you're losing too much protein through your kidneys, which can happen in certain kidney diseases. Severe protein malnutrition can also cause it. Burns or major hemorrhage can lead to protein loss too. Without enough protein pull, water tends to stay out in the tissues.
Makes sense. What's the third mechanism?
The third one is increased capillary membrane permeability. Basically, the capillary walls become leakier than normal.
Leaky capillaries. How does that happen?
This typically occurs with inflammation or immune responses. Think about burns, crushing injuries, or even severe allergic reactions. The inflammation mediators make the capillaries more permeable, allowing not just fluid, but also plasma proteins to escape into the interstitial space.
And if proteins leak out, they take water with them.
Yes, and they also reduce the oncotic pull inside the capillary, making the problem worse. This can be life-threatening, like with laryngeal edema in an allergic reaction.
Okay, leaky capillaries. And the fourth one?
The fourth mechanism is lymphatic channel obstruction. Remember that drainage system. If it gets blocked, fluid and proteins can't be returned to the blood.
So it just builds up?
Exactly. This can happen if lymph nodes are surgically removed, maybe during a mastectomy, or damaged by radiation therapy. Tumors or infections can also block lymphatic vessels. This leads to a specific type of edema called lymphedema, which tends to be harder and less compressible.
How does edema usually show up? What would someone notice?
Clinically, you might recognize edema simply as swelling. It can cause noticeable weight gain or make clothes or jewelry feel tight. A common sign is pitting edema.
That's the indent thing.
Yeah, if you press firmly on the swollen area for a few seconds and an indentation remains after you lift your finger, that's pitting edema. that shows that excess interstitial fluid is being displaced.
Can it happen anywhere?
It can be localized, like in a sprained ankle, or maybe more serious, like cerebral edema in the brain or pulmonary edema in the lungs. Or it can be generalized, meaning it's distributed more uniformly throughout the body, sometimes called anasarca. Often it's most noticeable in dependent areas, like the ankles and feet if you're standing, or the sacrum if you're lying down.
And I've heard of third spacing. What's that?
Third spacing is when fluid accumulates in a space where it's not easily available for metabolic processes, essentially trapped outside the normal ECF compartments. Think of fluid building up in the pleural cavity around the lungs, pleural effusion, or the pericardial sac around the heart. Even though the person might be quite swollen, this trapped fluid isn't contributing to their effective circulating volume, so they could actually be dehydrated in a sense.
Wow, that's counterintuitive. Swollen but dehydrated.
It can be. Overall, edema can limit movement, impair wound healing, and increase the risk of infection in the swollen tissues. Treatment really focuses on the underlying cause, maybe diuretics to get rid of excess fluid, elevating limbs, compression stockings, restricting salt, or sometimes giving 5-E albumin if protein levels are low.
Okay, that covers edema. Now let's shift to the master regulators. Sodium, chloride, and water balance. Sodium seems key.
Sodium is absolutely the king of the ECF. It's the primary cation, making up about 90% of the positive ions outside the cells.
And it does more than just attract water.
Yes, it's crucial for nerve impulse conduction, playing a role in acid-base balance, and it's involved in cellular transport mechanisms too. But its role in water balance is probably paramount. Where sodium goes, water tends to follow.
And the body has systems to control sodium levels.
Very tightly controlled systems. A key hormone is aldosterone.
Aldosterone. From the adrenal glands, right? On top of the kidneys.
Exactly. Aldosterone is a mineralocorticoid, and its main job is to tell the distal tubules in your kidneys to reabsorb more sodium back into the blood. And as sodium is reabsorbed, water usually follows it passively. In exchange for saving sodium, aldosterone promotes the excretion of potassium.
So it holds on to sodium in water, gets rid of potassium.
That's the gist. And aldosterone release itself is part of a bigger, really elegant system called the renin-angiotensin-aldosterone system, or RAAS.
Ah, yes, RAS. That sounds important. How does it work?
It's a cascade, usually triggered when your blood volume or blood pressure drops, or perhaps when sodium levels are low. Your kidneys sense this and release an enzyme called renin.
Okay, renin starts it off.
Renin then acts on a precursor protein from the liver to produce angiotensin the stuff. Angiotensin I doesn't do much on its own, but it gets converted, mainly in the lungs, by an enzyme called ACE.
Angiotensin converting enzyme.
That's the one. ACE converts angiotensin I into angiotensin II, and angiotensin II is the real powerhouse here.
What does angiotensin II do?
It's a potent vasoconstrictor. It narrows blood vessels, which immediately helps to raise blood pressure. But it also stimulates the adrenal glands to release more aldosterone.
Oh, bringing us back to aldosterone saving sodium in water.
Correct. And angiotensin II also stimulates the release of antidiuretic hormone, or ADH, which we'll talk more about soon, and it even makes you feel thirsty.
So the whole RAS system works together to increase blood volume and pressure.
Precisely. It's a critical survival mechanism. And because it's so powerful, many common blood pressure medications, like ACE inhibitors or angiotensin receptor blockers, ARBs, work by interrupting different steps in this cascade.
But the body usually has counter mechanisms, right? Checks and balances.
Absolutely. To counter the effects of RAS when blood volume or pressure gets too high, the body has natriuretic peptides.
Natriuretic, meaning causing sodium excretion.
Exactly. These are hormones like ANP and BNP that are released primarily by the heart muscle cells when they get stretched by increased blood volume. There's also urodalatin from the kidneys.
And what do?
They act as natural antagonists to the RAAS. They cause vasodilation, relaxing blood vessels, and they promote the excretion of both sodium and water by the kidneys.
So they lower blood volume and pressure.
Correct. They're basically the body's way of saying, okay, volume's too high, let's get rid of some fluid. In fact, measuring BNP levels in the blood is a really useful diagnostic test for congestive heart failure, as levels rise when the heart is struggling and overloaded.
Interesting. What about chloride? Does it have its own system?
Chloride is the major anion, the main negative ion in the ECF. It doesn't really have its own independent regulatory system like sodium does. It generally follows sodium passively to maintain electrical neutrality.
So if sodium goes up, chloride usually goes up too.
Typically, yes. It also tends to vary inversely with bicarbonate concentration, playing a role in maintaining acid-base balance, which we'll get to later.
Okay. Now let's really focus on water balance itself. You mentioned antidiuretic hormone, ADH.
Yes, ADH, also sometimes called vasopressin. This hormone is the star player in regulating your body's water levels, specifically the concentration or osmolality of your body fluids. It's produced in the hypothalamus in your brain, but released from the posterior pituitary gland.
And what triggers its release?
Two main things. The primary trigger is an increase in plasma osmolality. Basically, if your blood gets too concentrated, meaning too much solute, like sodium, or too little water-specialized sensors in your hypothalamus called osmoreceptors detect this and signal for ADH release.
Okay, so concentrated blood triggers ADH. What's the other trigger?
The other major stimulus is a decrease in circulating blood volume or blood pressure. If your volume drops significantly, say by 5–10%, even if osmolality hasn't changed much, sensors called baroreceptors located in your heart chambers and major arteries detect this drop in pressure or stretch, and they also signal for ADH release.
So ADH responds to both concentration and volume pressure changes. What does it do once it's released?
ADH acts primarily on the collecting ducts and distal tubules of your kidneys. It essentially makes them more permeable to water by inserting more of those aquaporin water channels. This allows more water to be reabsorbed from the urine filtrate back into your bloodstream instead of being excreted.
So it helps you conserve water.
Exactly. It helps dilute your blood, bringing the osmolality back down towards normal. ADH also plays a role in stimulating your thirst mechanism. Both actions work together beautifully to restore water balance.
That's a pretty sophisticated system. Osmoreceptors, baroreceptors, ADH, all working to keep water levels just right.
It really is. It allows us to maintain a remarkably stable internal environment despite huge variations in how much water we drink or lose each day.
But what happens when these delicate sodium and water balances are, completely thrown off? You mentioned tonicity earlier.
Right. Tonicity refers to the effective osmolality of a solution, basically, how concentrated it is with solutes that don't easily cross cell membranes compared to the inside of our cells. It determines how water will move across the cell membrane.
So how does that relate to fluid imbalances?
Well, we can classify fluid alterations based on tonicity. An isotonic solution has the same solute concentration as our cells. So giving an isotonic IV fluid, like 0.9% normal saline, won't cause cells to shrink or swell.
Okay, isotonic is balanced.
Then you have hypertonic solutions, which are more concentrated than our cells. If the fluid outside the cell becomes hypertonic, water will be pulled out of the cells by osmosis, causing them to shrink.
Cells shrink. Got it. And the opposite.
The opposite is a hypotonic solution, which is more dilute than our cells. If the fluid outside the cell becomes hypotonic, water will rush into the cells, causing them to swell.
Cells swell. That sounds potentially dangerous.
It can be, especially in the brain. Let's quickly look at some examples. First, isotonic alterations. You can have isotonic fluid loss, also called hypovolemia.
Hypo meaning low, ephilemia meaning volume, low volume.
Exactly. This is where you lose both water and electrolytes in proportion, so the ECF concentration doesn't really change, but the total volume goes down. Think of hemorrhage, severe wound drainage, or even just excessive sweating without adequate replacement.
What are the signs?
You'd likely see weight loss, maybe dry skin and mucous membranes, decreased urine output, a rapid heart rate as the body tries to compensate, maybe flattened neck veins, and eventually low blood pressure. If severe, it can lead to hypovolemic shock. Treatment is usually giving isotonic IV fluids.
Okay, and the opposite?
The opposite is isotonic fluid excess, or hypervolemia. Here, you gain both water and electrolytes proportionally, so the ECF expands, but the concentration stays normal.
How would that happen?
Maybe getting too much isotonic IV fluid administered, or conditions like hypoaldosteronism, where you retain excess sodium and water. Symptoms include weight gain, distended neck veins, maybe increased blood pressure, and eventually edema, potentially leading to pulmonary edema or heart failure. Treatment often involves diuretics.
All right, those are isotonic. What about the hypertonic ones?
Right. Hypertonic fluid alterations mean the ECF osmolality is too high, greater than about 294 millism. This is most commonly associated with hypernatremia.
Hyper meaning high. Natremia referring to sodium. High sodium.
Correct. Hypernatremia means a serum sodium level above 145 millieql. Because sodium is the main ECF solute, high sodium makes the ECF hypertonic. This pulls water out of the cells, causing ICF dehydration and cell shrinkage.
Brain cell shrinking sounds bad.
It is. The neurological consequences are usually the most serious. You can see confusion, lethargy, muscle twitching, seizures, and even coma. Other signs are related to the overall water deficit, intense thirst, dry, sticky mucous membranes, maybe fever, weight loss, low urine output.
What causes hypernatremia?
It can happen in a few ways. Often it's due to a net water loss or inadequate water intake. Think of someone who can't perceive thirst or can't drink on their own infants, the elderly, unconscious patients. Excessive water loss from things like high fever, profuse sweating, severe diarrhea, or diabetes insipidus, where you can't make or respond to ADH, can also cause it. Less commonly, it can be from gaining more sodium than water, like accidentally getting hypertonic saline infusions.
And treatment.
Treatment involves carefully giving fluids that are hypotonic relative to the patient's blood, like plain water orally if possible, or IV fluids like 5% dextrose in water, D5FW, or half normal saline, 0.45% ACL. The key is to correct it slowly to prevent rapid shifts in water back into brain cells, which could cause cerebral edema.
Okay, slow correction. Now for the other side, hypotonic alterations.
Hypotonic fluid alterations mean the ECF osmolality is too low, less than about 280 millism. This is primarily associated with hyponatremia.
Hypo meaning low sodium, less than 135 millieql.
Right. Low sodium makes the ECF hypotonic relative to the cells, so water moves into the cells, causing them to swell. This is called ICF overhydration or cellular edema.
And brain cell swelling is really dangerous, right? Increased pressure.
Exactly. That's the most life-threatening complication. Cerebral edema, leading to increased intracranial pressure. Symptoms can range from headache, confusion, and lethargy to seizures, coma, and even death if it's severe and develops rapidly. Other symptoms might include muscle cramps or weakness.
What leads to hyponatremia? It seems counterintuitive that low sodium could be from too much water.
It can happen in several ways. You can lose sodium, perhaps through prolonged vomiting or diarrhea, or using certain diuretics, or you might not take in enough sodium, but very often it's a problem of too much water diluting the sodium that's there.
Like drinking way too much water.
Yes, that's called dilutional hyponatremia, or water intoxication. It can happen sometimes in endurance athletes who rehydrate only with plain water, or in certain psychiatric conditions, or even from inappropriate IV fluid administration, giving lots of D5W. Another key cause is the syndrome of inappropriate ADH secretion, SIADH, where the body releases ADH even when it shouldn't, causing excessive water retention and dilution of sodium.
How is hyponatremia treated?
Treatment depends on the cause and severity. If it's due to excess water, dilutional, restricting water intake is key. If it's due to sodium loss, replacing sodium might be needed. In severe symptomatic cases, especially with neurological signs, small amounts of IV hypertonic saline, like 3% ACL, might be given very carefully and slowly.
Slowly again.
Yes, correcting hyponatremia too quickly can cause its own devastating neurological problem called osmotic demyelination syndrome. So slow and steady is crucial for both hyper and hyponatremia.
Okay, sodium and water are clearly linked. Let's shift gears slightly. What about potassium? You said it's the main inside ion.
Yes, potassium K+ is the major intracellular cation. About 98% of your body's potassium is actually inside your cells, where the concentration is really high, around 150-160 millieql. Outside the cells in the ECF, the concentration is kept in a very narrow critical range, normally about 3.5 to 5.0 millieql.
Such a huge difference. Why is that gradient so important?
That gradient, maintained largely by the sodium-potassium pump, is absolutely vital. It's the main determinant of the cell's resting membrane potential, the electrical charge, across the cell membrane. This is fundamental for nerve impulse transmission and muscle contraction, especially for the heart muscle.
So messing with potassium affects nerves and muscles, especially the heart.
Definitely. Potassium also plays roles in regulating intracellular fluid volume and osmolality, and it's involved in metabolic processes like depositing glycogen and glucose in liver and skeletal muscle cells. There's even evidence linking adequate dietary potassium intake to low risk of hypertension and stroke.
How is that narrow ECF potassium level controlled? Mainly the kidneys.
The kidneys are the most important long-term regulators. They filter potassium freely, reabsorb most of it back, and then can either secrete excess potassium into the urine or reabsorb more if needed, mainly in the distal tubules. Aldosterone plays a role here. Remember, it promotes potassium excretion.
Right, saves sodium, dumps potassium.
Insulin also influences potassium, shifting it into cells. Epinephrine can do that too. And importantly, changes in pH affect potassium levels.
How does pH affect potassium?
In acidosis, when there's excess hydrogen ion, H+ in the blood, H+ tends to move into cells for buffering, and to maintain electrical balance, potassium moves out of cells into the ECF, so acidosis can lead to hyperkalemia.
Okay, acid pushes potassium out. What about alkalosis?
Alkalosis is the opposite.
Right.
With fewer H plus ions in the blood, H plus moves out of cells and potassium moves in. So alkalosis can contribute to hypokalemia. It's a really important relationship to remember.
So let's talk about the imbalances. Hypokalemia, low potassium, less than 3.5.
Right. Hypokalemia can be caused by reduced intake, although that's less common unless someone is severely malnourished or has an eating disorder. More often, it's due to increased losses.
Like from where?
Gastrointestinal losses are common. Think chronic diarrhea, vomiting, laxative abuse, or drainage from fistulas. Renal losses are also very significant, often caused by certain diuretics like loop or thiazide diuretics, conditions like hyperaldosteronism, or even low magnesium levels, which impair the kidney's ability to conserve potassium. Also, when treating diabetic ketoacidosis with insulin, insulin drives potassium into cells, which can rapidly cause or worsen hypokalemia if not monitored.
What does low potassium do to the body?
It generally decreases neuromuscular excitability. Mild hypokalemia might be asymptomatic, but as it gets worse, you can see skeletal muscle weakness, often start in the legs and arms, progressing to smooth muscle atony, causing constipation, or even paralytic ileus. In severe cases, it can affect the diaphragm, leading to respiratory arrest.
And the heart effects.
Cardiac effects are major concerns. Hypokalemia alters the electrical activity of the heart, delaying ventricular repolarization. This can lead to various dysrhythmias like bradycardia or heart blocks. On an ECG, you might see characteristic changes like flattened T waves, the appearance of a U wave, and ST segment depression. It also significantly increases the risk of toxicity from the heart medication digitalis.
So pretty serious. How is it treated?
Treatment involves replacing the potassium, preferably orally if possible, but sometimes IV if it's severe or the person can't take oral supplements. 4-BF potassium must be given carefully and diluted, never as a rapid push, because that can be fatal. Correcting any underlying acid-base imbalance and addressing the root cause of the loss is also crucial.
Okay. Now the other side. Hyperkalemia, high potassium above 5.0 or 5.5.
Yes, hyperkalemia is often more immediately dangerous than hypokalemia because of its effects on the heart.
What causes high potassium?
It can be from increased intake, especially if kidney function is impaired. Think potassium supplements, salt substitutes which often use potassium chloride, or large transfusions of stored blood, potassium leaks out of stored red cells.
Sure.
More commonly, it's due to potassium shifting out of cells into ECF.
Like in acidosis, you mentioned.
Yes, acidosis is a big one. Also, any major cell trauma or lysis, like in severe burns, crushing injuries, or tumor lysis syndrome, releases large amounts of intracellular potassium into the blood. Insulin deficiency, like in uncontrolled diabetes, also impairs potassium uptake into cells. And finally, decreased renal excretion is a major cause, especially in acute or chronic kidney failure. Certain medications like ACE inhibitors, ARBs, and potassium-sparing diuretics can also contribute by reducing potassium excretion.
What are the signs of hyperkalemia?
Mild hyperkalemia might cause some restlessness, intestinal cramping, maybe diarrhea, sort of increased neuromuscular irritability initially. But as levels climb higher, it paradoxically leads to muscle weakness, loss of muscle tone, and even paralysis.
And the heart again.
The cardiac effects are the most critical. Hyperkalemia initially increases membrane excitability, which can show up on an ECG as tall, peaked Q waves and a shortened QT interval. But as it worsens, it severely depresses conduction, leading to widened QRS complexes, prolonged PR intervals, loss of P waves, bradycardia, heart block, and ultimately ventricular fibrillation or cardiac arrest.
Sounds terrifyingly fast. How is it treated?
Severe hyperkalemia is a medical emergency. Treatment aims to rapidly shift potassium back into cells and protect the heart. This might involve giving intravenous calcium gluconate to stabilize the cardiac membrane. It doesn't lower potassium but protects the heart from its effects. Giving insulin along with glucose. Insulin drives K+ into cells. And sometimes sodium bicarbonate if acidosis is present. Medications that bind potassium in the gut or dialysis might be needed to actually remove potassium from the body, especially if kidney function is poor.
Wow. Potassium balance is incredibly critical. Briefly, what about the other electrolytes like calcium, phosphate, magnesium?
Right, they're crucial too, though we have less time to detail them.
Right.
Calcium is vital for bones and teeth, of course, but also blood clotting, hormone release, nerve transmission, and muscle contraction. It's tightly regulated by parathyroid hormone, PTH, vitamin D, and calcitonin.
And imbalances.
Hypercalcemia, too high, can cause fatigue, weakness, kidney stones, and heart rhythm problems. Hypocalcemia, too low, leads to increased neuromuscular excitability, tingling, muscle spasms, even seizures, tetany. Phosphate is calcium's partner in bones, but also essential for energy in ATP and acts as an acid-base buffer. It's regulated alongside calcium by PTH and vitamin D. High phosphate, often seen in renal failure, can cause problems related to low calcium. Low phosphate can impair oxygen transport and cause nerve and muscle dysfunction.
And magnesium.
Magnesium is a cofactor for hundreds of enzymes and is really important for neuromuscular function and smooth muscle relaxation. High magnesium, usually only with renal failure or excess intake like antacids, can cause loss of reflexes, low blood pressure, and respiratory distress. Low magnesium, often linked to malnutrition or alcoholism, causes irritability, increased reflexes, muscle cramps, and potentially seizures and heart rhythm issues.
So many interconnected pieces, it really highlights the complexity.
Absolutely. Each electrolyte has its role, and they often influence each other.
Okay, let's move to our final major topic, acid-base balance. Maintaining the right pH. Why is this so important?
Maintaining your body fluid pH within a very narrow range, typically around 7.35 to 7.45, with 7.40 being considered neutral for biologic fluids, is absolutely critical for life.
Why so narrow?
Because even tiny shifts in pH, meaning the concentration of hydrogen ions, H+, can drastically alter the structure and function of proteins, especially enzymes, which control virtually all metabolic processes. Cell function, tissue function, organ function, it all depends on keeping pH stable. Remember, the pH scale is logarithmic, so a small number change means a big change in H+ concentration.
And the body is always producing acids.
Constantly. As part of normal metabolism, we produce two main types. Volatile acids, primarily carbonic acid, H2CO3, which comes from carbon dioxide, CO2, dissolved in water. It's called volatile because the CO2 can be eliminated by the lungs during breathing.
Okay, lungs handle CO2 acid. What's the other type?
The other type is non-volatile acids, sometimes called fixed acids. These are stronger acids produced from protein, carbohydrate, and fat metabolism, like sulfuric acid, phosphoric acid, lactic acid, and keto acids. These can't be eliminated by the lungs. They have to be buffered and then eliminated by the kidneys.
So how does the body handle all this acid production to keep the pH so steady? What are the defenses?
There are essentially three lines of defense. First, we have chemical buffer systems in the blood and tissues. These act almost instantaneously to soak up excess H+ or release H+ if needed.
Like chemical sponges.
Kinda, yeah.
Yeah.
The main ones are the bicarbonate buffer system, phosphate buffers, and proteins like hemoglobin inside red blood cells.
Mm-hmm.
Second, there's respiratory control.
The lungs breathing off CO2.
Exactly. Your respiratory center in the brainstem is very sensitive to changes in CO2 and pH. If acid builds up, you breathe faster and deeper, hyperventilate, to blow off more CO2, which reduces carbonic acid levels. If things become too alkaline, breathing slows down, hypoventilate, to retain CO2. This response happens within minutes to hours.
Okay, buffers are instant, lungs are minute to hours. What's the third line?
The third line is renal control the kidneys. This is the slowest response, taking hours to days to really kick in, but it's the most powerful and effective long-term regulator.
What do the kidneys do specifically?
The kidneys can excrete excess non-volatile acids, primarily by secreting H+ into the urine, often buffered by phosphate or ammonia to form ammonium ions. Crucially, they can also reabsorb virtually all the filtered bicarbonate and generate new bicarbonate to replenish the buffer system. This ability to regenerate bicarbonate is key for handling ongoing acid loads.
Let's quickly touch on the main buffer system, the bicarbonate carbonic acid system.
This is the most important buffer system in the ECF. It involves carbonic acid, H2CO3, which is a weak acid, and its conjugate base, bicarbonate ion, HCO3. The balance between these two determines the pH.
And there's a specific ratio.
Yes. Under normal conditions, the body maintains a ratio of about 20 parts bicarbonate to 1 part carbonic acid. This precise 20.1 ratio keeps the blood pH right around 7.40. The lungs control the carbonic acid side by regulating CO2, and the kidneys control the bicarbonate side. They work together to maintain that ratio.
Okay, so buffers, lungs, kidneys all working together. But what happens when these systems get overwhelmed? That's when we get acid-base imbalances.
Exactly. When the balance is disrupted, we develop an imbalance. We use the term acidosis to describe a condition that tends to lower pH, either due to excess acid or loss of base, and alkalosis for a condition that tends to raise pH, loss of acid, or excess base. If the pH actually falls below 7.35, we call it acidemia. If it rises above 7.45, it's alkalemia.
And these imbalances can come from breathing issues or metabolic issues.
Correct. We classify them based on their primary cause. If the problem originates from the lungs and involves CO2 levels, it's respiratory acidosis or alkalosis. If the problem originates from metabolic processes involving changes in non-volatile acids or bicarbonate levels, it's metabolic acidosis or alkalosis. So 4 main types.
How do we figure out which one it is?
We measure arterial blood gases, ABGs. This test gives us the actual blood pH, the partial pressure of carbon dioxide, PaTO2, which reflects the respiratory component, and the bicarbonate level, HCO3, reflecting the metabolic component. Analyzing these 3 values together tells us the primary imbalance and whether the body is trying to compensate.
Compensation versus correction. What's the difference?
Compensation is the body's physiological response trying to bring the pH back towards normal, even if the underlying problem isn't fixed. For example, if you have metabolic acidosis, low bicarbonate, low pH, your lungs will compensate by hyperventilating to blow off CO2, lowering PaCO2.
So the lungs help out with a metabolic problem.
Right, and the kidneys try to compensate for respiratory problems, although that takes longer. Compensation might bring the pH back into the normal range, fully compensated, or just move it closer, partially compensated. Correction, on the other hand, means the underlying cause of the imbalance has actually been treated and fixed, allowing the buffer components, CO2 and bicarbonate, to return to their normal levels.
Okay, let's briefly look at the 4 types. Metabolic acidosis.
Low pH, low bicarbonate. This can happen either from an increase in non-volatile acids, think diabetic ketoacidosis, lactic acidosis from shock or severe hypoxemia, ingestion of toxins like methanol or aspirin, or from a loss of bicarbonate like in severe diarrhea, or kidney failure where the kidneys can't regenerate bicarbonate.
What does it look like?
Symptoms might include headache, lethargy, confusion, progressing to coma. A characteristic sign is Kussmaul respiration's deep, rapid breathing as the lungs try desperately to compensate by blowing off CO2.
Okay. Metabolic alkalosis.
High pH, high bicarbonate, often caused by excessive loss of metabolic acids, most commonly from prolonged vomiting or nasogastric suction, losing stomach acid. Can also be from excessive intake of bicarbonate, like too many antacids, or conditions that cause the kidneys to retain bicarbonate, like hyperaldosteronism or diuretic use.
And the signs.
Weakness, muscle cramps, hyperactive reflexes, sometimes tetany, because alkalosis decreases ionized calcium levels, confusion, seizures. The respiratory compensation is shallow, slow breathing, and try and retain CO2.
Now for the respiratory ones. Respiratory acidosis.
Low pH, high PaSO2. This is always caused by alveolar hypoventilation, not breathing effectively enough to eliminate CO2.
What causes hypoventilation?
Anything that depresses the respiratory center, like drugs, head injury, paralysis of respiratory muscles, disorders of the chest wall, or severe lung diseases like pneumonia, COPD, or asthma attack that impair gas exchange. The excess CO2 builds up, forms carbonic acid, and lowers the pH.
Symptoms.
Headache, blurred vision, breathlessness, restlessness initially, progressing to lethargy, confusion, muscle twitching. Skin might be warm and flushed due to vasodilation from the high CO2.
And finally, respiratory alkalosis.
High pH, low PaSO2. This is caused by alveolar hyperventilation, breathing too much, blowing off too much CO2.
Why would someone hyperventilate?
Common causes include hypoxemia, low oxygen stimulating breathing, anxiety or panic attacks, hysteria, high fever, salicylate, aspirin intoxication, or even being on a mechanical ventilator set too high. The excessive loss of CO2 reduces carbonic acid levels, raising the pH.
What does that feel like?
Dizziness, confusion, tingling sensations, paresthesias, often around the mouth or in the fingers and toes, sometimes muscle cramps or even carpopital spasm due to effects on ionized calcium again, possibly seizures. The low CO2 can also cause cerebral vasoconstriction, reducing blood flow to the brain.
Wow. It really underscores how tightly regulated everything needs to be.
Absolutely.
Yeah.
Lungs and kidneys working constantly with the buffer systems.
So to wrap this up, what does this all mean? We've journeyed through this really intricate world of fluids, electrolytes, and acid-base balance from the smallest cell to the largest regulatory systems like RAAS and the lungs and kidneys. It's truly incredible how your body works tirelessly, moment to moment, to keep these critical components within such narrow, life-sustaining ranges.
Indeed. And I think this deep dive really shows us that these aren't just isolated concepts you memorize for a test. They form this highly integrated, dynamic network of checks and balances.
Right.
Understanding these mechanisms is absolutely key to appreciating the profound impact that disruptions, which can sometimes seem quite minor on the surface, can have on overall health and disease processes. It really encourages, I think, critical thinking about how our daily choices like diet and hydration, illness, and even medications can influence this delicate internal environment.
Yeah, it makes you think differently about just being alive, really. Here's where it gets really interesting, though. Thinking about that constant flux, the compensation, the body's amazing capacity to adapt. What's one practical way, maybe, that understanding your internal balance might empower you, the listener, in your own everyday wellness journey? Or perhaps even in how you approach or understand future health challenges you or someone you know might face. Something to mull over.
That's a great question to ponder.
Thank you for joining us on this deep dive into fluids and electrolytes, acids and bases.